Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, a randomized, double-blind, placebo-controlled, multicenter phase 2 study of the efficacy and safety of abraxane in combination with either docetaxel or pemetrexed in biomarker-selected non-small cell lung cancer patients by Martin J. Edelman et al. My name is Karen Reckamp, and I am Medical Director of the Lung Cancer and Thoracic Oncology Program at City of Hope in Duarte, California, United States. My oncologic specialty is thoracic oncology. Cyclooxygenase-2, or COX-2, has been shown to be overexpressed in lung cancer and plays a significant role in tumor development, angiogenesis, tumor invasion, resistance to apoptosis, and suppression of host immunity. COX-2 inhibition in lung cancer prevention has resulted in modulation of proliferation in bronchial tissue. Preclinical studies implicated taxanes in the upregulation of COX-2, and a number of trials have investigated COX-2 inhibition with chemotherapy with disappointing results. But there are lessons that can be learned from the experiences. The Cancer and Leukemia Group B 30203 trial was the first study to suggest a benefit from combined chemotherapy and COX-2 inhibition. The trial did not show a survival benefit for combined therapy in the overall population, but when COX-2 was assessed by immunohistochemistry, patients with high expression had improved survival when they received celecoxib. Those patients that did not have high expression demonstrated a potential detriment when receiving celecoxib in combination with chemotherapy. Following this study, the ENVOLT-4 trial randomized 561 patients to receive docetaxel and carboplatin with celecoxib or placebo and found no difference in progression-free survival or overall survival. They performed a retrospective analysis of COX-2 expression, but results did not demonstrate a predictive value of COX-2 by immunohistochemistry. Most recently, the Cancer and Leukemia Group B 30801 trial was presented, which randomized selected patients with elevated COX-2 expression to receive chemotherapy with carboplatin and gemcitabine for squamous cell carcinoma and carboplatin and pemetrexed for non-squamous cell carcinoma with celecoxib or placebo. The study was closed in October of 2013 due to futility without benefit from celecoxib. Despite this result in the COX-2 selected population, they performed an evaluation of the urinary metabolite of prostaglandin E2, referred to as PGEM. Those with elevated PGEM levels at baseline who received celecoxib in combination with chemotherapy had improved survival. Urine PGEM, quantified by liquid chromatography tandem mass spectrometry, has been found to be elevated in patients with non-small cell lung cancer and is inhibited by NSAIDs and COX-2 inhibitors. Siskey and colleagues demonstrated that urine PGEM correlated with intratumoral levels of PGE2, with reductions seen in both following celecoxib treatment. Furthermore, their phase 2 trial of celecoxib and docetaxel in patients with advanced non-small cell lung cancer evaluated decline in PGEM, and patients with a 72% or greater reduction in PGEM had a 14.8-month median survival, compared to 6.3 months in those with an increase or less than 72% decrease. Baseline and rate of decline of PGEM was associated with improved responses when analyzed in patients receiving chemoradiation in combination with celecoxib for stage 3 non-small cell lung cancer. A phase 1 trial evaluating escalating doses of celecoxib in combination with erlotinib found variable plasma PGE2 levels, but a dose-dependent decline in PGM required doses of 600 milligrams twice daily to reduce PGMs beyond 70%. These data suggest that PGM may be a useful biomarker for selection when investigating COX-2 inhibition as a therapeutic intervention. In the current study, eligible patients with advanced non-small cell lung cancer who progressed on first-line systemic therapy participated in a 5-day run-in period which they received the COX-2 inhibitor, aprecoxib, to determine the percent decline in PGEM. Those who had a 50% or more decline in PGEM were eligible for randomization to aprecoxib or placebo in combination with either pemetrexed or docetaxel as determined by physician choice and tumor histology. The use of 50% decline was based on aprecoxib dosing from a phase 1 trial with the combination of aprecoxib and erlotinib. Statistical considerations were based on the previously mentioned CALGB 30203 trial using COX-2 immunohistochemistry as the selection marker despite the use of PGEM for selection in this study. 72 patients were randomized, and progression-free and overall survival were similar in patients who received celecoxib or placebo with chemotherapy. Elevated baseline PGEM was associated with poor survival and potential detriment with docetaxel, suggesting a differential impact of the COX-2 pathway based on chemotherapeutic agent. Another randomized phase 2 study using aprecoxib or placebo in combination with erlotinib in non-small cell lung cancer used the same run-in period and decline in PGM for eligibility. 120 patients were randomized, and progression-free survival was similar in both the aprecoxib and placebo groups. In patients aged 65 and younger, a significant improvement in time to progression was seen with aprecoxib and erlotinib. The extensive investigation of COX-2 inhibition in advanced non-small cell lung cancer provides insights into this therapy for future study. The first is that COX-2 in archival tumor may not be a reliable measure of pathway activation at the time of subsequent treatment. COX-2 is induced by inflammation, and levels may change over the course of progression and therapy. We do not have studies that evaluate COX-2 by immunohistochemistry on fresh or recent biopsy samples, and this is not likely to be completed. Urine PGEM is a non-invasive biomarker that shows reliable association with current COX-2 activity and can be measured at multiple time points. Despite the disappointing results from the recent trials using run-in periods with COX-2 inhibition to assess decline in PGM as an eligibility criterion, the levels required were still less than the published 72% decline associated with improved patient outcomes. Baseline PGM may also be a viable biomarker for patient selection. The study by Edelman and colleagues serves as a new starting point for trials that will require prospective patient selection with a rigorous cut point based on available evidence. COX-2 is important in lung cancer pathogenesis and progression, and its role in immune modulation may lead to combination therapy with PD-1 and PD-L1 inhibitors in lung cancer. I do not believe this is the end of COX-2 inhibition in non-small cell lung cancer, but a time to learn from the past and move forward. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.